It's 5 o'clock. So I guess we'll get started. Just a few reminders for those of you at home. Please stay on mute unless you have a question. You can ask the question on the chat room. And either we can have you ask the question or we'll ask it for you. And so it's great that we're here in person, some of us, and it's great that we have a nice number of people that are still home, but still joining us. We appreciate it. The three chair of the committee, one is Marie. She'll be up in a minute. Mark is on today from South Carolina, and I'm Robert Kraus. So we'll get started today. So we welcome everybody, and we're going to start out with our liaisons. What? So. Oh, were you? Yeah, we're afterwards. So is it okay, Mark, if we have our liaisons come up? Who's?
Yes, come to order.
So I guess the first. Valerie is there. Valerie, you want to give an update?
Hi, yes. Hi, good evening. I'm joining remotely. I have a slide you could bring up. Good evening.
Wait, do you
I'm
have
Valerie.
You do have a slide?
Yeah, I have a slide I sent in.
Oh, so IT, can we share her slide, or is that going to disrupt everything? We don't have.
If she sent it
in, what's the slide?
She didn't send it in. She just has it right there. So
do you want to share your screen, Valerie? If you share your screen, you will see your slide.
Okay, I'm on two different systems here, so I won't. I'll just be, because I sent it in, but maybe they didn't get it. So anyway, good evening. I'm Valerie. I'm the lead Palliative End of Life Committee advocate, and I've served on this committee since 2019. And I can say in that short time that it's been a pleasure to be able to work with such dedicated investigators on developing important concepts, projects, and trials that have had such a direct impact for patients. The research we bring forward collectively as a SWOG committee is pivotal in helping to advance quality supportive care for cancer patients as well as their caregivers during the most critical times of their illness. This has been especially clear over the past few years during the COVID crisis, as both patients and providers have faced so many additional struggles. The slide you see briefly highlights the continuing work of this committee's advocates who each bring their unique knowledge and extensive patient and advocate experience to the research planning and development table. I began my own advocacy journey after losing my parents to cancer and then receiving my own advanced cancer diagnosis in 2007. My passion for research and advocacy led to my work with SWOG, the IBCIC, and other institutions and organizations, both nationally and internationally. Lee Jones has served as a SWOG advocate now for quite some time. He is the lead advocate for the Survivorship Committee, as well as being very active in this committee. He is a survivor of stage 4 colon cancer and also serves on the NCI Central IRB, and is a research advocate with a number of organizations and on many levels in the state of Virginia. Carol Siegel, our third advocate, is also a longtime SWOG advocate. Carol is the lead advocate for the GI committee, as well as being active on this committee. Carol's husband lost his life to pancreatic cancer, which led her to become a research advocate and being involved in her state of Massachusetts and nationally. She's also an advocate advisor for the National Pancreas Foundation and also works with ASCO and ACS. We're all thrilled to be part of this exciting work taking place in our committee this year, and we look forward to working together for our continued growth and the promise of new emerging concepts and trials yet to be. Thank you. I hope you're enjoying the conference.
Thanks very much, Valerie, and Carol and Lee are both here, and giving them an opportunity to come to the floor mic if you have any additional updates. Carol says no. And I don't see Lee here at the moment, but he has been updating along the way at other meetings, and so I think that's good. I wanted to also give Dr. Crew an opportunity to say a few words. Dr. Crew is our Executive Officer Liaison, and I wanted to give her an opportunity to say a few words.
Sure. So we heard a great talk this morning in the Cancer Survivorship Committee meeting, someone from the Office of Cancer Survivorship, specifically talking about a lot of unmet needs in terms of understanding survivorship concerns in patients with advanced cancer or metastatic cancer, which I think is very relevant to this committee. So I think that, and also the focus obviously on health equity and diversity, are going to be big buzzwords, I think, moving forward. I guess the other thing is that you know, for a lot of the NCORE studies, which are sort of out of the box studies, which often require additional funding, I think there's usually often an announcement from the Hope Foundation for seed grants, impact grants. And then we heard yesterday during our NCORE meeting about this new, I think it was youth R34 or U34 mechanism to potentially, the RFA hasn't come out yet. It's like the notice was published, but should be coming out soon. But it's specifically to get preliminary data that will then lead to subsequent larger trial through the cooperative group. So and up to $600,000 for 3 years. So that may be a good mechanism if you really want to understand, you know, the feasibility of your study, work out some of the measures. So I think that it was sort of tailor-made for doing a pilot study through SWOG. And then I guess the other training aspect is that the young investigator training course is starting up again. They had kept delaying they had already accepted applicants from last year, but they're going to be back in person this September, and hopefully for next year, I think the application process is usually around May. So that's a good way for young investigators to sort of, especially if they have an idea and they want to develop it through SWOG, it's a great way to get your foot through the door. So I just want to put a plug in for that too.
I just want to know, want the group to know that the Department of Defense has a program for pancreatic cancer. And in the year 21, they were remarkably short on supportive and quality of life palliative care proposals. And they're going to make special effort to encourage that. So this group should know that it'll be coming out, I don't know, in July, whenever they start to post their opportunities, but there's an opportunity there for some funding.
That's great, Carolyn. Thanks for continuing to bring these important notices to our attention. I know we can always count on all of you to do that. So thank you very much. Also, I have up on the screen our mission statement and objectives. I'm not going to read that.
No, on our original, we said that the nursing committee was going to give an update too.
Oh, yeah. Yeah, sorry. Yeah, Melissa, do you want to come up and do our nursing, let's see, oncology nursing professional?
Oncology research professional.
Research professional.
Yes. So liaison. So I just thought that I would quickly say that you can see the hand of the ORP committee throughout this whole conference. not that I had anything to do with it, but I've been blown away with everything that they have done, from the seminar this morning to all the training. And I think we've heard over and over again how sites and NCORs are losing research associates. And I know for me, being here has just revitalized me to go back and take all the information and hopefully turn that spark on in somebody at home. So I'm available. I can't wait to help review protocols that you guys write and offer practical tips on how to increase enrollment and retain patients. So thank you.
Thanks. That's amazing work that you are all doing because at the end of the day, without the coordinators and the nurses, none of the studies are happening. So we can come up with the best science, but we're not going to be executing any of it unless we have really outstanding folks like yourself. So anyway, I didn't have an opportunity to just welcome everybody. This is amazing. After 2 years, it's kind of odd to see some of you sitting on the dais with us here on the screen, and the rest of you in front of us. But I also wanted to extend my welcome. And also, Dr. Krause is going to be too modest to say that instead of being here today, he should have been in, where was it? Chicago, in being inducted into the American Surgical Association, which I guess is the top honor in the surgery world. And so I'm very honored to be here with him and for him to have prioritized SWOG over accepting that amazing honor. And I guess people need to be either really, really famous already or have passed away. So I'm glad you're the former.
or just old.
So anyway, congratulations on that. I also, as I said, have put the mission statement up and our objectives. These are ones that we will be continuing to assess and evaluate as through our studies that we're doing and following the trends as well. And so we will be, again, if you have any thoughts or ideas, if there's something that we're missing, please be sure to let us know, and we'll be continuing to revise as we go. Okay. So when we went into remote mode, one of the things that we were doing was called a wellness check-in. As we know that the many trends, which we call a syndemic of multiple epidemics of not only COVID, but social injustice. And now we have the Ukraine, Russia conflict war that's going on, has created just a lot of distress in our world. And so we've asked a few members to just stand up and say how things are going and with them in terms of encouraging us as our own wellness. And so we thought we would continue it, even though we're somewhat in person and hybrid. And the first person I wanted to call on is Dave Feldman, and he is online. So Dave, can you unmute? And we've asked people to just reflect on some of the positive and negative impacts on yourself, your patients, your caregivers, and practices, and what strategies you're using to maintain your resilience and hope.
Sure. I don't know if I have any super wise words, but you know, when I found out that I was going to be asked to do this, I really stepped back and, first of all, thought how exciting it is that SWOG is in person again. And as someone who studies hope and has created interventions for hopefulness, that gives me a lot of hope. I'm just sorry I'm not able to be there in person. There were just some not movable appointments and things that I had to see to here in San Francisco. And I'm really sorry I can't be there. I also was thinking a lot about, you know, what we've all been through the last 2 years. And now what we're going through and what we're seeing, of course, at a distance, sometimes others that we care for and love very much personally going through in Ukraine. And I think that everything that we've been through, the syndemics, as Marie just talked about, really highlights for me the fine line between hope and despair, between hope and cynicism. I mean, I have to say, as someone who does research on hope, and as a psychologist who thinks of myself as very much a hope therapist, is one of the main targets of intervention for me is people's hopefulness. I've had so many people say to me over the last couple of years, either we need more hope or there is no hope. And for me, this has just fueled my resolve and my enthusiasm for continuing to do research and to understand what hope means, what are the dynamics of hope in people's lives, how can we help to bolster people's hope when it's down. And you'll hear later, a concept that's been developed by Dr. Korn and myself to use a single session hope intervention for women with metastatic breast cancer. I'm sorry that I won't be presenting it. Marie will actually, she's been kind enough to present it for me, given that one of those immovable conflicts that I have is actually during the rest of this meeting. You know, I always describe myself, and Marie asked to share, like, how do we get through it and help the people that we care for get through it. I always describe myself as a hopeful pessimist. And people laugh when they hear that, because people often say to me, Dave, you study hope, you're a therapist, you must be like this really optimistic person. And people are often surprised to hear me say that I'm a hopeful pessimist. And what that means to me, the pessimist in me really believes, or maybe it's the realist in me, I don't know, really believes that bad things are going to happen, that the world is going to throw us all kinds of bad stuff, all kinds of curveballs. And I think all we have to do is look at our world today and over the past couple of years to see that. But I think the hopeful part of the hopeful pessimist in me is this sense of resolve, this sense of belief that when we come together, we can nonetheless overcome these things. We can find ways of solving these problems. That doesn't mean it's easy. And again, I think one of the things that proves that is that SWOG is once again back in person, and that we are soldiering forward the best we can. And so I tap into that sense that it's okay to be down. It's okay to be a pessimist. It's okay to be a realist. It's okay to realize that things sometimes are awful. And you can simultaneously have the hopeful belief that there are things we can do to move forward together. So I think that's what I want to share with you, and thank you for the opportunity to share it.
Thanks, Dave. And we hope that you have an awesome rest of your afternoon with your other commitments.
Thank you.
The next person I wanted to ask to come forward was Jamie Myers, who offered to say a few words about where she's at and her place.
Thanks, Marie, and thanks for letting us all kind of check our pulse and our temperature. I think that's a very worthwhile strategy. So extemporaneously, what have been the positive and negative impacts? Well, I think the negative impact was that sort of abject fear that we all went through when COVID first raised its head and we began to isolate ourselves into family pods to try to protect our loved ones. And then the impact that it had on all of us at work, trying to maintain safe practices of care for our patients. On the positive side, though, I think the silver lining to this whole event has been us finding new strategies and ways to do things in a different way. And thank the Lord for Zoom, right? It allowed us to maintain our family relationships. It allowed us to continue to work in a productive way. I'm very grateful to the University of Kansas Medical Center because we were able to put into place protocols fairly quickly to allow us to continue to do research. And I was also very fortunate that some of the research we had ongoing was leaning in a virtual direction. So we were able to maintain that pace. And as far as what we're doing currently to maintain resilience, I like to play tennis, and you can really work a lot out on the tennis court. So I'm very grateful for that as well. Thanks for the opportunity.
Thank you. And Jasmine Coffey Dunning is a new member of our committee, and she's also from UAB, and she agreed to say a few words as well.
So I guess for me, some of the positives was having technology kind of negate the negative impacts. So we were still able to recruit for a lot of our studies using email, e-consent, Adobe Sign, all those things. So the work never stopped. So that was always a good thing. It always kept my mind going. So that was nice. And the strategies that I'm using to maintain is, so I have a type A personality. So I kind of like to control certain things. Obviously, we can't control nothing right now. So I picked the thing that I can control, and that's cooking. I can control my cooking. So I cook a lot at the house. This is probably the longest I've gone without cooking a meal. So when I get back home, I am going to cook up a storm.
Thanks, Jasmine. And Melissa, you were gonna say a few words.
So I was sitting there listening to everyone else, and I enjoyed everything that they said. And I thought back to the beginning of COVID when, as an old RN, although hadn't been to the bedside in 30 years, I thought I would be taking care of patients with garbage bags and oven mitts because there were not enough PPE. There were not enough ventilators. I envisioned, you know, the back of our cancer center filled with cots. It was horrible. I didn't have to do that. I did go and give vaccines. I did work at the COVID testing site. And I prayed every day for those on the front line who were doing things that I'm not sure I could have done, that they would have the strength to do what they were doing. But out of the bad, I will say that, and not because of COVID, but because of some other horrible things that happened in our world over the last 2.5 years, I think there's been an emphasis on DEI, and I'm thankful to be part of the Take Action series. And I hope everyone will join us at the cocktail party within a cocktail party tomorrow night. Look for the balloons. It's caused me, and I think many others, to recognize what is important, and that's our health and our families and our friends. So there's always something good out of every bad. Thank you.
Thanks, Melissa. And thanks to all of you who are continuing to make us in palliative care be sensitive to our own needs, as well as, and that makes us be able to take care better for our patients. I'd like to move on to our plenary session and introduce our speaker. Please come to and welcome to the podium, Dr. Aishwarya Sabaya. And I had my nice introduction all set here for you on my computer, and then it just slept.
It's all good, Marie.
So just give me 1 second to say a little bit more formally how wonderful you are. So
We are so rusty. I gave her the most awkward hug I've ever given in a really long time. But yes, good to see you all.
So, here we go. So Dr. Sabaya is, so, you know, we're always so casual, but I'm going to be a little more formal, is a medical oncologist and palliative care and integrative medicine physician at the University of Texas MD Anderson Cancer Center. And she is uniquely qualified, having completed as an overachiever 3 clinical fellowships at MD Anderson in developmental therapeutics, medical oncology, and palliative medicine. Holds many peer-reviewed grants from the American Cancer Society, the Andrew Sabin Family Foundation, and our very own SWOG Hope Foundation. She's going to be telling us a little bit about that one. And she is also the PI on the global study for the comprehensive characterization of clinician experience and wellness during the pandemic. And in the process, she developed and validated a novel measure of preparedness and self-efficacy. Because she didn't have enough to do, the MD Anderson has recently appointed her as the Director and Faculty and Academic Wellness officer at UT MD Anderson. So please, let's give a warm welcome to Dr. Sabaya.
Thank you so much. Thank you. Thank you. How should I advance the slides? Okay, perfect. Wonderful. And if I can borrow this, is that- I'll just turn it over. Here you go. That's good? Or we can share that.
No, you can, that's good.
Perfect.
You're good.
Okay, wonderful. Let's see. Waiting tape. Okay, good. No, really, this is just surreal. So this is actually my first in-person meeting in 2.5 years. And I mean, from the time getting to the airport to getting to here and making it here, I'm just many reasons to be thankful. Let's just say that. Thank you for making time for a topic as important as professional wellness of our workforce. And I really have to thank our committee's co-chairs, Marie, Mark, and Robert, because this is as if we need a reason for why we're talking about this. We're going to spend a bulk of the time today really focusing on where we can make an impact. And so we will spend a few minutes actually defining this concept of professional wellness. And I truly want to emphasize that phrase, professional wellness. And then we'll really go into briefly highlighting the drivers of burnout. We want to spend as much of our time today and any opportunities to discuss and come up with ideas as a group on a solutions focused approach. What are we going to do about it? And so this is why we were all so eager to meet in person. And so let's spur some ideas and some conversations from here. There are a number of graphics out there that capture burnout in healthcare. And the reality is that when you look at the burnout as a workplace experience, it really comes down to what have been the repercussions? What are the consequences and who are paying the consequences for this? And so between broken relationships, substance use, depression, physician and healthcare provider suicide, as well as workplace consequences like turnover, productivity and professional effort, patient satisfaction and quality of care, and increased medical errors. These are all domains that have already been characterized as impacted by the workplace experience of our clinical teams. There are key organizations that have invested quite a bit of time and resources into characterizing the problem. And so this particular graphic is from a series through the National Academies, and they really have just excellent resources online if you'd like to explore their one of their collaboratives related to the workplace experience. But the complexity of this graphic, especially along the perimeter, is intentional. It's truly meant to show how many different dimensions can ultimately impact an individual person's well-being and how many dimensions can impact a group's workplace experience. More importantly, how each of these dimensions can be different from one workplace to the next. So I'm not sharing all of this because it's not widely known or to discourage any of us from working in this space, is that despite its complexity, we are still obligated and motivated to make an impact. And so between the characterization of the National Academies, and the work done by organizations within oncology. So this particular one is work done through ASCO, and this highlights some of the organizational risk factors for why cancer care clinicians are at risk. And you see similar themes that have been reported across different specialties, and they center on a lack of perceived control over their workday. And it's a lack of control across multiple dimensions. And so we take this work and we put this now in the context of the pandemic. And we can see, based on our individual experiences, on how really each of these elements has gotten that much worse when we're in the current state we're in, which is fractionated as a healthcare delivery entity. And so I promise that we're gonna turn this around. It's not meant to put you into And so here we are in a line of work that's inherently so intense, and on top of that, you add elements to the workplace experience. You have to understand. We have to understand what domains these fall under, right? And so you see that when you start to see the themes emerging, whether it's the workload and job demands, efficiency and resources, organizational culture values, the meaning in work, you can see how if we design our interventions conceptually for these areas, we can actually implement that across different sites, regardless of what that local culture necessarily is. And so within each of these domains, we have individual ways that the workplace experience, the individual factors that impact why they impact that domain negatively. We have the work unit factors, we have organizational factors, and we have national factors. These are all meant to give us the exact outcomes where we can measure and outcomes we would intervene on. And so the goal of these types of aggregated information is to spur those ideas on which domains should we focus on for a particular intervention we would put together, and more importantly, how would that domain and in turn that intervention be related to other elements of the workplace experience. And so when we look at how we can best understand and reconcile with this even further, let's see if this will cooperate. Where am I pointing? Okay, there we go. Perfect. So we can see how these driver dimensions ultimately impact the workplace experience. If they are less optimal, we see how the progression is towards burnout, cynicism, inefficacy. And we see how when it's more optimal, it's the opposite of burnout, which is engagement, vigor, dedication, absorption. And so with this in mind, we truly want to look at professional wellness, right? So you take the various conceptual models, the various categorizations, and distill it even further. This becomes crucially important because you want to define what professional wellness is. And so to do that, the Stanford model is one that's often looked to within those who work in the workplace well-being area, right? So this is having professional fulfillment as the center of the measure and recognizing that what we intuitively may think of as wellness, personal resilience, is a component of professional fulfillment. I say that because it is one component of professional fulfillment. What you see are two other major domains that form the workplace experience, and both of those are organizational. Those are not domains that are an individual based, that each one of us can take and change individually. But those two are organizational, the culture of wellness at your organization and the efficiency of practice at your organization. This approach becomes crucial because overwhelmingly, wellness interventions have been focused on the individual. How can you take better care of yourself? How can we help you take better care of yourself? But the fact is that the approach to wellness really has to take a bigger step back and say, how can the organization take better care of its people? Because that factors heavily into what the professional fulfillment model ultimately is. And so the current approach to wellness has always appears to be more reactive than proactive across different centers. So when you think of wellness at your institution, odds are there may be a group, there has to be a group through HR, and there may be peer support groups informally, or there may be certain departments or certain centers that appear to be more tight-knit than others. So you see this wide variability. Almost always it's reactive versus proactive. When you look at these domains, look at the same figure that we saw earlier, but now look at it with the lens of, well, when do you become aware that something's not right? When do you become aware when there's a problem with each of these domains? And you only become aware when there is a problem enough to be grossly perceptible by everybody. So what you're faced with is, we know the drivers, we know the underlying factors. How do we create a system, and how do we create a study to study a system that is more proactive, that picks up changes earlier and picks up changes 2 to 3 orders before they have the downstream impact on the wellness of your workforce? And so in this context, we have to start with what the actual types of interventions are. And when it comes to wellness, this is a summary image from a colleague of ours on resources that are available. And so it's going in order from left to right of education on health and impairment, on stress, physical activity, and then onto what are the prevention type wellness resources, what are the treatment related wellness resources, and disciplinary wellness resources. So it goes along a spectrum of severity, if you will. What you can see is that there's a overwhelming focus and awareness of the harsher interventions, the harsher offerings, the disciplinary offerings, the treatment offerings. Whereas those that are centered on education, those that are centered on prevention, those that are centered even on modifying the workplace experience, that's not even on here. And we know that too. We know that a majority of the professional fulfillment is driven by organizational factors. That's really nowhere on the guidance that's provided to any clinical team member on wellness. And so we really see, when you start to look at it through this proactive versus reactive lens, organizational versus individual wellness, you start to see the gaps that are in the current approach. So what can we do as a community of oncology stakeholders? And so we're here for solutions, right? So that's what we're going to spend the next few minutes talking about. We have to make operations as part of the research. Anything wellness related, I'm in a large cancer center where everything is, personalized, precision, immunotherapy, something, or your choice of buzzwords. And then you walk in there with words like wellness, like well-being, like holistic, a person-centered workplace experience. And so nothing makes people cringe like a room full of scientists cringe like this conversation. But we still have it. We have it fearlessly, and we talk about it with the same rigor that we do with our phase 1 clinical studies, with our the latest target that was identified in vitro. And it's because the work that we do is methodologically as rigorous, and it's done in a way that's both transparent and implementable and scalable across other healthcare settings. So when you think of impact of a well-designed study related to the workplace experience and the wellness of people, you're truly impacting the entire workforce in oncology and beyond oncology. And so for us, it's advocating that clinical research includes research that is on the team that's delivering the clinical care. And that includes advocacy, not just to legitimize this area of work, but legitimize it with the funders. You can't imagine how little I found, or how esoteric I found when I tried to search who funds this type of work, who is going to fund a study or studies or a program related to burnout or to solutions, even if it's solutions focused study, who's going to fund that? And it is a very, very, very limited list, very limited list. And so our next task is to take a feedback-driven approach to professional wellness. If it's a concept that seems, we saw those two graphics, right? There's a reason you were meant to not necessarily be able to read all of it. You can access them online if you'd like, but the point of it is that there are truly that many factors. And so when you're designing a study in this space, how are you going to know which areas to focus on, and how will we know, because that's going to factor heavily into what measure we select, right? How are we going to measure impact? It's because you do that by going straight to the community that you're looking to impact. And so it's deciding which population you want to approach for that particular study. So if it's advanced practice providers, if it's physicians, if it's members of the research team, decide on the setting that they're in. Are they in a more in a rural area? Are they in a large urban area? Are they virtual employees? This is a new factor we've had to take into account. If we're going to do a study on the workplace experience, we will need to capture what proportion of time they spend on site, face-to-face, what proportion of time they spend remotely. And so these are all the characteristics of the target population that we'll capture when we design a study in this space. This helps us truly understand what the need is, because the worst thing you can do is to invest time and resources from an institutional entity, from a national organization, and offer an intervention that actually doesn't really answer any of the concerns of the workplace where that intervention is implemented. I do yoga, I have nothing against it, but that is not the control and flexibility that's listed as the driver, one of the drivers of burnout. And so the next is maintaining the core values in the wellness interventions design and implementation. So when I took on this role, and part of the homework that I did was I read through the free text comments of we do an employee survey, a large employee survey every couple of years. And so and it goes out to all 20-something thousand members of the workforce. And so you start to you see the themes very quickly, right? It's completely anonymous, so the free text is colorful, to say the least. And so you see the value, you see the themes that are emerging when it comes to why their workplace experience is great and why it isn't. And so it's so simple. When you filter it down, it's clear that we could clearly see that the needs fell into specific buckets. And so we're not talking about staffing, we're not talking about any need in a practical sense. This is need in a conceptual sense and need in terms of their values. There has to be the air of personalization, that what was designed was in response to feedback. We designed this in response to focus groups XYZ, surveys XYZ, so that the population we're serving, they know that this came directly from feedback from them. There is a need for transparency. It's to understand exactly why we're doing it, how we came up with it, and what our hope and our intentions are by designing this study. And this became important because the goal isn't really about increasing revenue all the time. The goal, and even though that's practically blasphemous to say in certain settings, this is truly about keeping our workforce together. And there is no oncology without an oncology workforce. And so in that context, maintaining a simplicity in the interventions. I came across one wellness program that had 4 or 5 phases and 3 subtopics under each phase. It was one where you look at it and you truly couldn't understand what it is they were trying to do. And so the simplicity, regardless of how complex professional wellness may be as an entity, the simplicity in the intervention is a must. authenticity, understanding why you're doing what you're doing and why and what your intentions are as an individual and as a team who designs an intervention in this space. And then responsiveness. This was a principle that was raised across multiple settings, and even completely unrelated to our topic today, which was you provided a platform for feedback, you get feedback, and the person giving the feedback has no idea what happens downstream from there. And this is a theme that's repeated in different settings. And so it's a key priority for any wellness intervention that we design for there to be closed loop feedback, responsiveness. And so if you have a concern, you raise it, we will close the loop. If you have if you're giving a bit of feedback, we will keep the thread of communication open and share updates with you periodically on what was the impact of you taking the time to share the feedback. And so these conceptually emerged as themes in the dissatisfaction that was written in said colorful language. And so being solutions focused, right? So we have this information. The problem really has been characterized. I mean, there are unique dimensions because we're in a pandemic, we're a syndemic state, and the workplace is different for different people in a very literal way. But the fact is that the problem has been well characterized. And so it's really when we design this, when we get the baseline survey, that should really be the extent of problem characterization, because the rest of it is solutions focused. And then not losing sight of the unique needs of each team member. This is one we really grapple with within our group, and we see across in our conversation with colleagues, is in a desire to maintain a unified workplace, we clump everybody's experience together. And I'll clarify what everybody is in a minute. And so when we look back at the data, what we see is that the workplace experience of different team members, there are themes that are that unite us, but there are also themes that are very unique to that group. And so if you're truly looking to move the needle in the experience of your team as a whole, you have to have a system in place that's mindful of unique needs as well. And so this is this is part of an even larger graphic, but it talks a little bit about what are the domains that are identified as areas that are problematic by the role. So for this one, as an example, and this study is from 2019, but for nurses and non-clinical allied health, you see the common themes, but you also see where it's not the case, So if you have a intervention that's focused on, inadequate staffing, patient death and suffering, moral distress, and feeling undervalued by other team members, the fact is if that's what the intervention focused on and you're opening the study to all members of the healthcare team, there may be a large subset whose needs aren't met by what you're offering. And so this becomes important because by choosing the domains wisely, we also have to make sure that we choose the right population wisely for that. Because when we're asking the time of any groups in our institution, we want to be sure that we know upfront that they should get a benefit from it. And so in this context, there are this particular study, and if you get a chance to deep dive into it, please do, and I'll gladly dive in again with you. This becomes incredibly important because when we measure across the population, but we also we do our analyses by the departments and divisions and roles. And so the personalized precision concept, as well established as it is with our oncology through our oncology hats is equally important when we look at the workplace experience. And so I've covered quite a bit of concepts in our short time together, and it really involves moving how we define what is quality of care from patient-centered domains and really be inclusive and add the team-centered domain to the quality of care. And so healthcare teams' wellness is the singular glue that holds the oncology enterprise together. And when we hear of turnover in our fields with our colleagues and our team members in any role, changing industries, changing jobs, changing roles, there is some amount of turnover that's appropriate and expected with an individual's goals and values and what they hope to accomplish. But with what we're seeing and recognizing how the workplace experience is truly impacted, it is nothing short of a crisis to not intervene. And so I'll pause there, and we have so many opportunities as a cooperative group, as a community of oncology stakeholders, as a multidisciplinary community to study this. And so our conversations start with ideas, domains, what you've observed, your individual experiences, and our collective advocacy to funders of research, of cancer research, research overall, to prioritize this area in a meaningful way so that we can carry out some of these ideas. And so I'll pause there, and incredibly thankful to our chairs for making time for this topic. And I'm optimistic for a good discussion.
Thank you.
Marie was, I was going to say, you're looking for that the emoji in Zoom for the applause. That's why.
Right? I don't know how to do it in person
You're like, what
anymore.
is going on?
So those of you on Zoom, please feel free to put your questions and comments in chat, and we'll read them. And we'll start with a live person.
Wow.
Dawn Hirschman's gonna.
Sort of. After a long day. Well, first of all, thank you for that really insightful talk. You know, it's been a long day, but we started our day at 7 in the morning with a lot of the, site PIs and coordinators from a lot of the SWOG sites, talking a lot about turnover and what that means for clinical trials, what it means to have to put a pause on accrual because of high turnover, of inadequate data, of not being able to do the follow-ups on time, and about quality of care in general, both to our patients on clinical trials as well as to patients off. And one of the things in terms of thinking about interventions aimed at the physician is how to measure the downstream impact, because that's come up with a lot of the trials that have been proposed. How does it affect patients? So in thinking about any intervention that we might do, I think it's important for us to think about what are those meaningful endpoints that we can show. Not that our own well-being isn't important, but if we're thinking about it in the cooperative group, we have to sort of sometimes measure these concrete things. So, I would say, like, looking at the impact on clinical trials and clinical trial enrollment or quality of clinical trial data is something we can measure. Looking at the impact on delays or something very concrete is something that we can measure in terms of the impact. I don't know what your thoughts are about that, or if you've thought about it from a clinical trials perspective.
Absolutely, without a doubt. Thank you very much, Dr. Hirschman. And so this is exactly what we want to talk about, right? We need to make sure we're measuring the right things, and we are measuring it in a way that is rigorous. And so the downstream impact, the impact of those in this, those who are impacted by an individual, is without a doubt what will be characterized. So that'll be the downstream impact both on the team dynamics and the patient dynamics as well. So from a team standpoint, it is measuring and there are validated measures for each of these, by the way, as touchy-feely a concept as it sounds, expressed, perceived, and received gratitude, engagement at work, a sense of feeling valued at work, turnover intentions, it's a sense of belonging at work, and and of course burnout. But burnout for me should really be very low on the list of things to measure, just because it's such a complex entity. So if you put that as your primary outcome, I wish you the best in moving that needle. But you can move the needle on individual components. The metaphor, death by 1,000 cuts, right? We can move them, and so those individual components we can measure. Patient-centered measures, there are measures for patients' level of engagement in their healthcare healthcare interactions, how activated they are, and how they feel the quality of communications, the level of interest and engagement of the clinical teams in their care, and so and of course, patient satisfaction is always on the list. So I clearly feel the same about that as I do about burnout as a primary outcome. But there are rigorous ways methodologically, and many of the concepts I just said are 3-4 item questionnaires. So we can measure change based on a singular intervention in domains that matter both to us and to the powers that be at our workplaces. So I appreciate that question. So.
Yeah,
Dr. Meskins.
I have to comment because I've been working on this topic for a very long time and I've lectured on it extensively, but I've covered the noble aspects of it, but when it comes down to it, it's the number of hours. It's the number of hours that you work per day, the number of hours that you work per week, the number of hours that you sleep or don't sleep. And that contributes to things that you can measure: errors, mistakes, misjudgments, catastrophes, and they've all been measured in other disciplines, in truck drivers, for example. And I think it's a very approachable problem, but we need to be able to take the time to measure these parameters, and we know what some of those are. We all know that and it's been demonstrated again and again. When you get beyond 16 hours a day, you start to make simple mistakes. When you get out to 20, you make errors. When you're out at 24, you have serious misjudgments, et cetera, and you can look at that and compound it with the number of hours in the week that you work. Or if you're 50 years old, you can get away with 5 hours of sleep or less. When you're 60, you can't do that anymore. And when you're 70, I need 8 hours. So I think there is a lot of very practical things. We just need to make our mind at that being important. Yes, we have to change the whole dynamics of the institution and the whole dynamics of medicine, from corporate benefit to benefit of the patient and benefit of the physician and the team.
Absolutely.
Thanks for that comment. We have one question online, and then we're going to have to move on. But this has been extremely enlightening. From Banu Symington, Dr. Symington asks, can you unmute? Do you want to ask your question?
Sure. Great talk, Ishwarya. I loved it. Hi. I feel a lot of cognitive dissonance because the leadership at my hospital, at every hospital I've been at, has told me they understand burnout, they care about burnout, but then they keep putting more meaningless tasks in my work bucket and they don't provide help. My work is about to double on April 18th when we roll out Cerner, and I'm not going to get any help, and I feel burned out already. So how can I take what you've told me and and implement something in my personal life to make myself less burned out.
So, Banu, I feel your pain and you're absolutely right. You're absolutely right. So the solution first starts with getting these decision makers and leaders in a room and flashing one image about what professional wellness is and how the organizational factors, what a large proportion of responsibility that they take on the wellness of their workforce, because odds are they will get you gift cards for sessions at a yoga studio before they streamline the amount of, crap we have to put on our notes in the chart and whatnot. Sorry, this is being recorded, right? That's nowhere near the colorful language that was in the free text comments of that. So it's opening their eyes to what professional wellness is and really looking at them and saying, this is your responsibility. This is not about my breathing exercises. The second is getting the legal team members in the risk compliance groups of people and finding out what is the bare minimum that needs to be done. We have education module after education module that we're required to do once a year. And it's always, it's a requirement from X, Y, and Z. Insert your favorite acronym, CMS, JCO, whatever. And so, but the question is what is it that they require and how does that requirement compare to what you're making me do? Do I need to do this 56 question quiz that I have to get right, which I have to keep doing until I get it right, on how to, extinguish a fire with a fire hydrant, whatever those things, or is it a level of awareness that that these entities want you to have? And so it's streamlining what's a requirement, but having those conversations with the right people, Banu, and that's why I brought up legal and compliance, et cetera. If I go to my chair and ask these, I'm going to get some stock answers back, and it almost always involves understanding and this and that, but it's not really, the buck doesn't stop anywhere with him to make those changes. But if it's driven by a national policy, then going to the risk and the compliance team members and working directly with them, suddenly the conversation doesn't become about going to your chair with a idea. It's about going to an institutional entity with a solution on how to meet the needs, and then a solution that can be implemented across all the departments, not just yours. And so this is not something anyone would ask an individual to take on their own. But if you come together as a group, a small group who's committed to professional wellness and addressing operational inefficiencies, you can divide and conquer by going to the top entity and then making that change across the institution. And it may just take you as an individual to raise this as an issue, and this is an approach for a solution. So.
Thank you so much. And I know that we can continue to have conversations about this after in our various cocktail inside a cocktail hour.
That's what I plan to have, is a cocktail inside a cocktail today. Thank you. Thank you.
So we're going to move on to our developing study updates, and Dr. Vincent Chung is online, and can you unmute Vincent, and we can go on to, oops, sorry, your report on 2016. Hang on a second while I'm trying to make this advance. Okay. Your slide is up, and I hope you're unmuted.
Okay, great. Yeah, well, thank you. And, it's great to be back with everyone again. One of the great things, again, about Zoom is that, I've been able to actually, communicate with my investigators in Korea this morning, now in Seattle, and in a couple of minutes, I'll be in San Francisco. So we're kind of moving around the world in a very short period of time. But this is a S2016, which is a randomized phase 3 trial of a primary palliative care intervention to improve quality of life in patients with metastatic pancreatic cancer patients, as well as family caregivers. And we all know in terms of the rationale behind this is that, with pancreatic cancer patients, there's a lot of physical as well as psychological aspects of their disease that really impacts their quality of life. And unfortunately, we have a lack of, supportive medicines to really be able to handle this shortage across the United States. So what we're planning on trying to do was actually have a advanced practice nurse be able to provide this intervention across through, the SWOG network to all the patients and family caregivers. So trying to find a scalable approach of how do we actually handle this demand that we need for more supportive care physicians and nursing staff across the country. So on the right-hand side, you can kind of see the schema. We've actually discussed this several times, but basically patients with metastatic pancreatic cancer, as well as the family caregivers, would be randomized to the intervention arm or the attention control arm. And the intervention arm actually consists of telephone sessions with the advanced practice nurse, as well as a resource manual that really kind of directs them in terms of managing many of their symptoms as well as psychological concerns. So we were planning on accruing 238 patients, and we had submitted the R01 grant. So just to give you an update in terms of what has transpired over this time. And at this point, I am also a hopeful pessimist, but we've actually submitted the grant 3 times so far. The first time we got a score of 13th percentile. So we were actually right above the funding line. Based upon the comments, we actually revised it, resubmitted it. We got a score of 24th percentile. We took those comments and we revised it again. And most recently in February, the grant was actually not discussed. So at this point, I am really a hopeful pessimist. Virginia and I actually met and spoke to also Dr. Bakaitis, and we appreciate all the support in SWOG. I mean, I can't emphasize this enough, but all your support has been really very valuable in terms of, helping us along on this journey. But we are in the process of actually reevaluating and actually submitting this as another grant going forward. So one of the comments we got was that, don't give up. Some of the people, it took about 5, submissions before it eventually got funded. This is a very important project, and we are going to move forward in terms of resubmission.
Vincent, thank you for your persistence and your pessimistic optimism.
Okay. So any questions for? I don't see. Is there anything on the?
No, nothing on the chat.
Okay. So the next thing project we're going to talk about. Dr. Blank, you can go to the podium. So
somewhere out
there. So this project, which this committee has prioritized and really was sailing through the system, and then was there something in IT you were? Oh, okay. So point at you. Okay.
Will do.
So, but then the steering committee didn't review it well. And so we're sort of back to the drawing board. And so, yeah, Dr. Salmon can't be here today, but Dr. Blank, who's the co-lead, is going to give us an update of where we are and where we're going.
Thanks for the invitation. I hope we're not all the way back to the drawing board, but I am going to discuss a SWOG 2106, a limited institution feasibility study to estimate the prevalence of depression in patients making a first oral request for medical aid in dying. Just to quickly remind you, medical aid in dying or death with dignity is now legal in 12 United States venues. All the ones doing so by legislation, not by Supreme Court ruling, require the patient requesting aid have decisional capacity. Separately, the incidence of depression in patients seeking MAID has been estimated at about 25%, but that figure hasn't been verified. Other trials have suggested it may be as high as 75%. And it's extremely important to determine what that number is, because up to 60% of psychiatrists feel that depression renders patients incompetent to actually utilize MAID. Physicians who are involved in MAID prescribing the lethal medications can mandate psychiatric evaluation for competence or capability, but they actually do so less than 4% of the time, despite these high rates of depression. Now, proactive screening for depression is absolutely inconsistent across centers specializing in medical aid and dying, and we just completely lack knowledge about the true rate and significance of depressive symptoms at end of life in relation to medical aid and dying. But we do know from other diseases that treatment of depression, even in patients who are near end of life, does reduce the desire to die. So the real question is what if we identified and treated clinically significant depression in patients requesting MAID? Would they have less of a desire to actually take the lethal medication? This is really topical, and I just added this slide. So an eating disorder specialist in Denver published a case series on patients with anorexia nervosa who were seeking MAID. And one of her patients who died was a co-author on that paper, which I found very exciting. The Colorado Sun picked up the story, and all I can tell you is the backlash among US psychiatrists for allowing this patient to use a legal procedure was absolutely brutal, excuse me. So it just reiterated the ethics of allowing patients with any mental illness to use MAID, whether it's okay, whether it's not okay. And I think this is a great time for the trial. So the original goal was to do a fairly large phase 2 trial with the objective to accurately determine depression rates that would allow us to power a phase 3 trial where we actually randomized patients between treating depression and not treating depression and saw whether or not their urge to use MAID went away. This was rejected by the NCI steering committee for a variety of reasons, and I'm not going to go into all of them, but their comments to me and to the other investigators suggested their understanding of the study, of its goals, and to be honest, of MAID itself, were not completely optimal. And that's all I'm going to say today. So this is our current proposal. I'm going to do it without an arrow, I guess, since the people there wouldn't see it anyway. We're going to take people who are making their first verbal request for MAID, and just recall that patients have to make 2 requests that are separated in time to give them a bit of a cooling off period. We'll consent them and give them a specialized questionnaire, the PHQ-9. If they refuse, we're still going to try and follow them and see what happens. Do they take the medications? Do they not? If they accept it, then we're actually going to find out whether they have moderate to severe depression, in which case we're going to offer a mental health referral. And if they don't have depression or have mild depression, we will still follow them for study outcomes. They do have to be adults. That's a requirement everywhere for utilizing MAID. And reminder, they have to be terminally ill with a less than 6-month prognosis from their underlying disease to actually use MAID in any state where it's legal. So the objectives and details are shown here. Again, we just want to see the feasibility. We want to know if people who are really pretty desperate to die will bother to go on a study, and will they actually fill out a questionnaire, even though I don't think it's particularly onerous, but I'm not a patient, and I want to, obviously empower them to do so or not do so if they're willing. We also want to see if they're actually willing to accept psychiatric referral at the end of life. It is clear that if we do offer referral, it's got to happen fast. And by definition, it's got to happen within 15 days because a lot of patients take the medication on the very first day they're eligible. So one of the goals of the study is to make sure we have enough money to get them in to see the psychiatrist very, very quickly. It's clear that we're going to have to conduct a trial at so-called high performance specialty centers where lots of MAID patients are seen, such as OHSU. I've already have 5 signed up to do the trial who are very, very interested. And we think that we could easily accrue 30 patients over 1 or 2 years at most. We are going to apply for seed funding. It seems to be really well suited to seed. And I don't want to give poor Dr. Hirschman a heart attack, but I was intrigued by her comments last night about the U34 mechanism. Here's a study where we want to find out if something is feasible. Here's a trial where we want to validate a tool used in other diseases in a very unusual setting. On paper, it looks great for a U34, but I'm afraid it would probably be fairly unpopular at a national level. So Dawn and I will talk more if it's even remotely on the table, as well as with the co-chairs of your committee. So I believe that is it, and I'm happy to take any questions if we have time. I remain incredibly excited by this possibility.
And thank you again for your persistence.
Thank you.
So it seems to me and we have some of our NCI colleagues here, that this is the perfect scenario for the U34, because the major issue is that we've never done anything like this before. We don't know if we can. We don't know if we can accrue these patients and if patients will accept it. And the whole issue of something being so out of the box makes it really challenging to get through a steering committee, right?
Yes.
So the whole point of this is to do it and to have the funds to be able to give for the psychiatric referrals. So because it's a funded mechanism. So it seems like this would be the perfect test case for that kind of a mechanism.
Well, thank you for not shooting it down. And when I bashed the steering committee review, it wasn't the NCI, it was my colleagues. I would love to explore this more. I think this is a little bit out there, but so is the grant.
Well, I want to thank you for your concept. I think it's very
Could you please
interesting.
also introduce yourself?
I'm Lucy Ganzar, and I'm the DEI champion for lung. But I think this is a wonderful concept, and I hope it is funded. But since this is more common in Switzerland and Europe, have they done some more studies, or is there any data at all?
No, almost everything out there is basically descriptive. The average
case
patient
study.
is this age, this gender. Sometimes if they try really hard, they'll go into the reasons. They lose autonomy near the end of death. But no one has tried any kind of intervention to see if we can affect MAID rates, which is one of the things that makes this so unique.
Well, I wish you success.
Thank you. Well, thank you guys so much for inviting me. I really appreciate it.
Thanks, Dr. Blanky. Really appreciate you, as I said, and your persistence. So moving from developing to active studies.
Shwari, do you have any update on the HOPE, the CAPC?
First,
I'm sorry.
Krista Browning-Bliss was
you're
going
right,
to
you're right, I'm sorry.
report on
I apologize.
behalf of Dr. Sun. That's okay.
So Dr. Sun can't be here today. We all know her. She's it's spring break for her kids. But Dr. Braun-Inglis has really been a driving force for this study and the ability to give the exciting news she's going to be talking about.
Yes. Thanks, Dr. Krause. So I'm the nurse coordinator on the SWOG 1820, a randomized trial of altering intake and managing symptoms intervention for bowel dysfunction in rectal cancer survivors compared to a healthy living education control. So it's a feasibility and primary efficacy study. Where's the, Dr. Krause is actually one of the co-chairs, the arrow.
That you're clicking that, yeah, that's the only.
Oh,
this one. There you go.
Okay, so this is our study team. It's been a great study team to work with over the last 3-4 years. And then, okay, and this is the schema. So it's a randomized intervention for rectal cancer survivors. It's a telephone intervention. It's either patients are either randomized to health coaching or attention control, where they get some American Cancer Survivor or American Cancer Society, sorry, my glasses, American Cancer Society information through a telephone intervention as well. And then we have follow-up at week 18 and 26. The really exciting thing I have to report is we're just about to our accrual goal. And that's on our next slide, I think. So this says as of, sorry, this is as of,
This one was.
this is an old one.
Yes.
This is an old one, sorry.
Yeah.
Okay, I think this is an old slide.
Nope,
Okay.
Go back.
Okay.
That's the one we got, but
Okay.
there's an update to this.
There's an update, and we're actually at 91 of 94. So as of 2 days ago. So, and we're going to close the step one accrual on Tuesday, actually. So this has been great. Like throughout the pandemic, we've actually been able to accrue. I give a lot of credit to Dr. Sun, Dr. Krause, the whole study team. It's been really great to be able to offer patients this kind of intervention throughout COVID and everything. So thank you.
Well, I just want to also, and just to, we can close before they got to 94 because of the lead-in. Just want to explain that, what that, and why we know we're going to complete the accrual.
Oh, we know we actually have over 100 patients registered to step one already, or 111, I think. So we're all set. So.
Yeah, it's very exciting. So.
And I bet there's a lot of clapping emojis that I can't really see because I can't see everybody there. Dr. Spy, do you want to come up real quick and give your update on our other active study?
I just love that Krista's practices in Hawaii. And so getting a call with her usually means that it's dark in one of our places when we do it. So perfect. What I'll do is, so we have our serious illness conversations study that was funded by the Hope Foundation. And so this is a pilot feasibility study for the implementation of a remote learning serious illness conversations module among healthcare providers caring for persons with cancer. And so we have activated the study. We are, we obtained the baseline assessment, which should take about 15 minutes. It's all purely online. We're measuring the individuals' their baseline hopefulness, their baseline burnout values, level of engagement, and their self-efficacy in medical communication. Then they immediately get access to the CAPC study, and if their institution isn't a CAPC institution, they can access it for free through this study. They have 2 weeks to complete the course. It's a five module course. Each module takes anywhere from 30 to 40 minutes to complete. And so a total of 3 hour investment, 3.5 hour investment. And then once they complete the CAPC modules, they get the immediate post-assessment, which is the same measures, and then 1 4 week down the road. And so our accrual goal is 100 clinicians. So these are either physicians, nurses, nurse practitioners in any discipline who provide care for persons with cancer. And so if this sounds like something you do in your day job, please join the study. You're welcome to join the study. Just send us send me a quick text or an email. But we're 35% of our way through to the accrual goal. So fingers crossed. Fingers crossed. And those who complete the study and the post-study 15-minute survey, they get an incentive of a $150 gift card sent to them. So some Starbucks money, if you will, now that we're in Seattle. Perfect.
Thank you. Yes, so our active studies are very active and getting ready to complete. Let's move on to our closed study, and Dr. Kraus is going to give that update.
I'll just give a couple minutes on S1316 that we've been following for years, and it's been closed for a little while now. This was the ultimate accrual that we saw. You can see it was as we all know, it was a novel design with a randomized and non-randomized portions of the study. This one, that one.
A minute. There you go.
So just to sort of update where we are and what we're doing, we're in the midst of preparing the primary manuscript. We're actually fairly, hopefully by the end of the month. It's actually a fairly complicated analysis, as you can imagine, with multiple different outcomes. We actually submitted an abstract to ASCO that was accepted as a poster, but we withdrew it because this is worthy of an oral presentation. And since that time, actually, we've had some fairly exciting analysis that was completed on some of the individual quality of life, malignant bowel obstruction focused outcomes that may actually show an indication of an improvement for those that underwent surgery. And so these are the other things that we have data on, and we're going to be doing other things in the future, including looking at qualities and preference-based quality of life, utilization, et cetera.
I love the title of your manuscript, Good Days.
good days.
I would
Yes.
strongly suggest submitting it to ASCO Quality.
Yeah,
Because this is much more in line with
Yeah.
that meeting. It won't get as lost as it might in a big meeting like ASCO. And I imagine depending on the way you frame the title, it would do quite well. Yeah.
thank you. Yeah, I appreciate it.
And so this data will be available for others to do analyses on after you get your primary analyses published, or can you say a little bit more about that? Because it looks
So-
like there's a ton of data here
Yeah.
that
this-
people would love
so,
to look
Listen,
at.
we go by the rules of SWOG, and of course, nothing can be done until the primary manuscript is out there. We do have leadership, of course, on a lot of these other outcomes, but there are, we have a sort of an in-depth table of potential things that we'd like to look at, but, and we have a series of investigators, as you can imagine, from a lot of different sites. There's a lot of people that are part of the team, but certainly if anyone has an idea, please approach me, because we do have a lot of data.
And the other really novel part about this, of course, it was carried out in our Latin American sites as just a reminder. So that's another really important piece for us to keep in mind as this exciting results come about. So now we're moving on to our new business, and this is again a very hopeful and exciting time for us despite COVID. Hope has been one of our main concepts that we are studying, and I want to see if Dr. O'Rourke can unmute and come back on to talk about our first new concept under development.
So I am here, yes. And
Perfect.
This is Dr. Korn and Dr. Feldman had developed this HOPE intervention, a single session of about 2 hours that is a cognitive behavioral virtual group experience for about 12 people that breaks down HOPE as goals, pathways, and agency, and includes a little app that goes with it and a follow-up. It was tested last spring, concurrent with the SWOG spring meeting, and had good reception from the faculty and staff that took it. So Dr. Korn and Feldman are lining up a single arm study for advanced metastatic breast cancer on endocrine therapy to measure adherence to the endocrine therapy as their outcome. And they're lining up funding on a shoestring, but it'll be done at the Prisma Health Center, and Lauren Fowler is also involved in that, and that's gonna that'll be finalized and likely happen this summer. The thing I'd like to suggest is the choice of the outcome tool for adherence was discussed in the PRO committee, and I've in the course of today I've seen Dr. Henry using the Voiles adherence in the 2010, and then the people at Michigan proposing a different adherence by Wilson. So I'll be interested in some input or suggestions on the best way to measure adherence for endocrine therapy. And they'll be putting this study together as a pilot this summer, as a prelude to a randomized study, hopefully in SWOG someday.
Mark, thanks a lot for that intro and update. And I know that some of us did the professional HOPE enhancement workshop, which was really excellent. And so really looking forward to submission of this or getting some pilot data from this out of the generosity of the funding that's available through Prisma, and hopefully a resubmission to HOPE Foundation as well, so we can have the data that we need to go forward with a larger study.
And on the professional side, they're also working up this HOPE intervention workshop for providers, as a provider well-being intervention.
Perfect. Thank you so much. And now our next concept under new business is being presented by Dr. Myers. So Jamie, take it away.
Thank you, Marie. Good evening, everyone. I've really been enjoying collaborating with Dr. Spakaitis, O'Rourke, Sabaya, and Perajuli on a study that we are preparing to hopefully pilot soon, that we can ultimately bring a concept back for work within SWOG. So this pilot proposal is Prepare for Your Care, a nurse-facilitated advanced care planning intervention for adults with advanced cancer. And Prepare for Your Care is actually an interactive website that was developed by Dr. Rebecca Sidori at UCSF. And it is specifically designed to help people who have serious illness of a variety of types to gain the skills to have serious illness conversations with their loved ones, as well as their healthcare team. And so the website has a series of vignettes, video vignettes that are 2 to 3 minutes in length that walk people through the 5 steps necessary to do advanced care planning. This is available now, but was studied in the primary care setting and has not yet been studied in outpatient oncology setting, and that's what we'd like to do. So we have submitted a grant application to the Palliative Care Research Cooperative Group to hopefully fund a pilot study for us. The goal for our pilot is to adapt the available messaging that's being used for the Prepare website currently and workflows to be consistent with something that would be practical and feasible within outpatient oncology. And the way we're going to accomplish this is twofold. First, we'll be doing a series of focus groups with key stakeholders such as patients and their care partners, but also listening sessions with healthcare professionals. And we'll be forming community advisory boards, both in the catchment area of the University of Kansas Medical Center, but also University of South Carolina, Greenville, where we plan to conduct the study, because we'd very much like to have a high percentage of focus on people who self-identify as Black. The website was designed to be culturally sensitive across a number of diverse groups, but has not yet again been tested at the oncology setting. So this is where we're going to start our efforts, knowing that there are other groups that we'll want to focus on as well. Once we gather this information and adapt the workflow and messaging, then we'd like to do a feasibility pilot with that information and enroll up to 15 dyads of adult patients with advanced solid tumors and their care partners, which we're defining very generously as anyone that patient identifies as someone who's close to them, who is involved in their care. And again, we would try to enroll at least 50% of people who self-identify as Black. The primary outcome will be feasibility. So we'll be looking at the ability to recruit and retain our 15 dyads, but we'll also be measuring change in advanced care planning engagement. And there's some really nice validated instruments that are short and succinct, one for the patient and one for the caregiver. We'll look at whether or not taking part in this intervention has any kind of negative effect in terms of distress. In primary care, the data said no, anxiety and depression was not enhanced by working through this intervention. And then we'll also look at measuring satisfaction with communication with the healthcare team. So cross your fingers that we'll get good news in June. So I'm also going to talk to you about a suite of pilot studies that are in various stages of development.
Can I ask you a question about the last?
Oh, okay. Question first.
So targeting 50% African Americans is not easy. And so I've got 2 questions. One is, can that be just underserved populations, or is it focusing only on at least 50% Black, meaning Hispanic populations or Native Americans, et cetera? And then do you have strategies in place? Do you have experience in targeting that higher percentage of?
Great question. So the answer to your first question is the way we wrote the grant, which we did submit already, did focus on African-American population to start with. The answer to your second question, forming those community advisory boards with representation from those populations, is how we're hoping to build trust in the community and enhance our chances of success. Because we know that probably will be a challenge.
This is only in Kansas City?
No, also University of South Carolina and Greenville.
Oh, great.
So
Okay.
we will have both populations. Kansas City, we are a minority and underserved NCORE, and we do have access to Truman Medical Center, who serves a very high percentage of African-American population. So we're hoping that that will help, but you're right, it will be a challenge. Looks like there's some more questions. I think you were at the mic first.
I just want to commend you on the fact that you're stating at the beginning 50% African-American. That means that your study is going to be applicable to that population. And I think particularly having Greenville as a site, that you'll be able to accrue that without a problem. So congratulations. Thank you.
Thank you. I appreciate the encouraging words. Yes.
And I just wanted to comment, I'm from Spartanburg. We're right next to Greenville, and through a moonshot grant, a moonshot engagement grant that we received a year ago, and we just received another, we were able to form a community advisory council that is, that the primary aim of it was to engage our African-American community and increase our enrollment onto the Moonshot Biobank protocol. So if I can offer my assistance, I am right there.
You're going to be my new best friend, Melissa. Thank you. I want your email before we leave tonight. So do you want me to go ahead and move on?
Sure.
Okay. So the other suite of studies that we have in process has to do with 3 symptoms that are a very high priority to all of us, as well as the NCI, and that would be cancer-related fatigue, cancer-related cognitive impairment, and sleep disturbance. We feel that that milieu of symptoms occurs very commonly together, and there's a lot of cross-population, if you will, impact that fatigue has from sleep disturbance, as well as cancer-related cognitive impairment has from sleep disturbance, both of which are further impacted by distress that can happen as a result of cancer diagnosis and treatment. Our hypothesis is that if we can have interventions to improve sleep, we should have a positive downstream effect on reducing cancer-related fatigue and improving cognitive function, both of which then would have a positive impact downstream on health-related quality of life. So these studies are designed twofold: better ways to assess objectively fatigue and cognitive function, but also to employ interventions that would help with sleep disturbance. And so we're specifically looking at sleep hygiene, as well as something called the Ready Watch, which is a wrist-worn actigraph that measures sleep metrics that's been developed in conjunction with an app that provides sleep hygiene content to the wearer. The sleep metrics are fed back to the wearer in terms of total sleep time, sleep efficiency, but ultimately what's called a Ready score, which is a number between 0 and 100, which is an objective measure of their fatigue throughout the day based on their sleep patterns and their cognitive effectiveness throughout the day based on their sleep patterns. The algorithm acronym is SAFETY, and it was developed by the Department of Defense. And one of the co-investigators, Dr. Lauren Fowler, who's I think joining us on Zoom tonight, was involved in that development. So we're really excited to get to collaborate with her. So we are applying for a number of grants. The good news is that the first one that you see reflected here on this slide has been funded. So Prisma Health has given an internal seed grant, yay, to Dr. Fowler, Dr. O'Rourke, and Dr. Matt Hudson. And this particular study will be a single-arm pilot focusing on women with breast cancer who are receiving aromatase inhibition. The other 2 studies that you see reflected here on the slide, both will be involved men with prostate cancer who are receiving androgen deprivation therapy. The second one here on the slide will be a resubmission to the Hope Foundation. That's due July 1st. Our initial effort was scored well, not ultimately funded, but we were encouraged to resubmit. So we have taken those comments to heart, revamped, and we'll be coming back with that revision. The third study that you see here, slightly different study design, which I'll talk about in a moment. We're submitting this to the Oncology Nursing Foundation for an RE03. So in general, these study designs are very similar in that a patient will be provided with the Ready Watch. They will wear it for 30 days prior to it being turned on to give them feedback about their sleep metrics. So this will establish a nice baseline of what their current sleep behaviors are and their sleep efficiency. At the 1 month mark, the device will be turned on to provide them with real-time feedback. The previous 30 days of sleep metrics will be available to them, as will prospectively real-time data. At that point, they'll also have access to the sleep hygiene content to help them hopefully make good decisions about their sleep behaviors. And then we will be collecting a number of patient-reported outcome measures, specifically looking at, from the Promise 29, we'll get anxiety, depression, health-related quality of life, and cancer-related fatigue. We've got the Promise 8-item short form for cognitive function, and we have the Pittsburgh Sleep Quality Index. The voice measure that you see here is a measure of their person's sense of control over their healthcare situation. And then ultimately we'll be getting those patient-reported outcomes at months 2 and 3. What's different about the third study is it actually will be a randomized trial, so that the men with prostate cancer on androgen deprivation therapy will be randomized 1-to-1 to get the Ready Watch and sleep hygiene content alone, or the Ready Watch and sleep hygiene content in conjunction with a virtual 4-week customized cognitive behavioral training for insomnia intervention. And we'll look at those same outcomes. So everyone light candles that the Hope Foundation and the Oncology Nursing Foundation will look favorably upon our grant applications. And I guess there might be time for questions on these as well.
Yes, there's time for questions. So I will ask one of the first ones. The selection of your instruments, can you talk a little bit more about, your, there's so many things you would wanted to measure and that you do want to measure, but, how did you sort out your outcomes and your measures?
Okay, great question. And before I go there, I should also highlight that to screen people to take part in the study, we would want them to score an 8 or higher on the insomnia severity index, so that we know that we'll have someone with a clinically significant problem and we could hopefully, get change. So how do we select our instruments? Well, we very much like the Promise measures. We like the fact that they are succinct. We like the fact that they were specifically developed with oncology patients in mind. The Promise 29, actually, we're using the most current version that I believe is called Promise Preferred. I think that's what it's called, because it will give you an overall score of health-related quality of life, but has the short forms embedded in it for anxiety and depression, as well as fatigue. I've been using the Promise Cognitive Function 8-item short form for the last several years, and I feel really comfortable with it. And I'm just now getting familiar with the Pittsburgh Sleep Quality Index. We did an internal pilot at University of Kansas for men with prostate cancer on ADT, and we conducted a CBTI intervention, and we used that instrument. Voices is new to me, so I'm going to learn about it. Yes, you've got a question, Kate.
Yeah, my question is your selection of your patient population. Was it because of insomnia being related to the androgen deprivation as well as the hormone therapy, or kind of what were your thoughts behind those populations? Because sleep is such a huge issue for so many cancer patients.
Well, great question, Kate. So actually, initially, the grant that we submitted to the Hope Foundation was a dual population. It was breast and prostate. So that's one of the revisions that we made, so it'd be a little less heterogeneous. But I was particularly interested in the men with prostate cancer in the previous pilot that we conducted, because we've been doing interventional work to try to reduce cardiovascular comorbidities and also to measure cognitive function over time. And as a part of our qualitative interviewing of the men, in addition to the intervention that we were doing, which was diet and exercise, we learned a lot about sleep disturbance. And of course, for that particular group, being on ADT, that itself with the reduction of testosterone messes up circadian rhythm. But then you combat that with hot flashes and nocturia, and you've kind of got a triple whammy. Yeah. So we will actually customize the sleep hygiene content for that population to help talk about strategies that will help mitigate those two things, in addition to changing sleep behavior. And then women with breast cancer, we know it's a huge issue, right? Sleep disturbance and cancer-related fatigue go hand in hand. So
it's great. It's great. And I think it's some of the things we have going on in cancer care delivery, where we're actually looking at, tools. These could be things that could be added in the future. So I think it's great.
Thank you. Frank.
Yeah, Frank Maskins, I would definitely second those thoughts. And they're examples of exactly what needs to be done that we were referring to earlier regarding the whole subject of fatigue and burnout. Studies like this, where they have quantitative differences and you're measuring them effectively and it's meaningful. And I'm just curious, where are these written up more? I'd love to read more details about the studies.
What was the last part? What were they written up? Do you have any abstracts or anything written more on besides, they're still working on the concept?
You mean the abstracts about the Ready Watch in the other population, or?
Yes, yeah.
Well, all three of these studies.
The 3 studies that you're presenting.
So these are concepts that have not yet been completed.
Okay.
The study that I mentioned, though, that we did already has been accepted for publication in the Oncology Nursing Forum and should be out any day now. So I'm excited about that.
Great.
Hi, I'm Noelle Aring from the University of Michigan, and I just had a question about how you plan to deliver the CBTI. Is that going to be, and who will be delivering it?
I heard you say CBTI, but I'm really hard of hearing. I apologize.
Sorry, these masks really do. So I'm Noelle Aring from the University of Michigan, and what I was interested in is your CBTI intervention, how that was going to be delivered and by who.
You say you are a CBTI nurse?
No. Who, in your intervention, who will be delivering CBTI?
Okay, and I apologize.
No.
My hearing deficit's getting worse every year. So actually, it's something that I will be conducting myself. I was able to get some advanced education and have partnered with someone at our institution who's the director of our sleep lab. And so she has mentored me in the process of that process. And so I actually have had the experience in the one pilot now, and this will be my second opportunity to take that forward. It's really fascinating work. I've really been enjoying it.
Do you envision, as you make this larger, do you envision other nurses delivering the CBTI?
Sorry?
Who do you think, if in a larger study, who would be delivering the CBTI? Other nurses?
Oh, so in the current pilot, we're not having a large enough sample that we're going to need to bring on additional practitioners yet. So your question is a good one for our future larger study. It's how we would centralize that, because we feel like it can be done virtually. That's how we've done it in the past. And so if we have a centralized intervention, much like Virginia has done, we think that might be a successful model within SWOG.
Before I get to thank you for your questions, we have a couple of questions online from Dr. Dizon. He said 2 things: that digital engagement is prepared to help the projects related to Ready Watch, and that they would love to provide time on their agenda to hear about it. Will you be excluding people already using an electronic watch like a Fitbit or an iWatch?
So that's an interesting point, and thank you for that interest. The way we understand the current technology from Ready Watch and the safety algorithm is this device, the Ready Watch. Y'all can come see it if you want later. Was the device that was specifically designed for, but they are compatible with Fitbit and with at least one other wearable device. So they're trying to kind of branch out. But
great. And the second question, comment from Dr. Eric Rowland, that he states that CBTI is a more effective treatment than sleep hygiene, and was this considered, and put a reference in the chat, and that anxiety could also be measured and considered as an important mediator or moderator. Do you want to comment on the?
So I would agree that probably CBTI would be the superior of the two. What we're interested in seeing is how much superior. If we can get close to a non-inferior situation, wearing the Ready Watch and having a sleep hygiene in education would be a pretty low touch intervention that would be really disseminatable. Whereas to have a CBTI intervention requires a lot more bandwidth. So it would just be nice to look at them head to head, something that we'd like to accomplish in the pilot, see how different they are. And it may give us further fuel to do something from a very practical perspective.
Thanks. Melissa, do you want to ask one more question?
I just wanted to tell you that we participated, and I'm sure a lot of others did, in a URCC study that was for insomnia that tested a yoga intervention, cognitive behavioral therapy, and then a health education, which was the control. And we didn't have any difficulty, and I don't think any other sites did either. And they did it at Prisma also, I think, where they found somebody that could deliver the cognitive behavioral therapy intervention on site. And that person was, vetted through URCC, and then we taped the third session to make sure they were following everything. So don't let that be a barrier, because it has been done before.
Awesome. We had to talk about that as well. Okay. Thank you, Melissa.
Great.
Thank you.
So thanks. And thanks so much, Dr. Myers, for all of those updates on our developing concepts.
Oh, we have one more.
Yes, I know.
Oh, I'm sorry.
And we have one more, but because this was related to both Dr. Braun Inglis and Myers' concepts, I wanted to just make the announcement now before our last one is presented that you've heard now from many advanced practice nurses, and that tomorrow there is a session at from 10 to 12 that can't be missed. That's looking at the oncology advanced practice providers' ability to enhance our research. And so I just wanted to put another extra special plug in. It's available on Zoom for anyone there too. So please make sure that you are there tomorrow. That's the place to be. And so let me turn it over to Dr. Kraus, who's going to talk about, introduce our last developing concept.
So I'm going to introduce Jonathan Sham, who is an assistant professor of surgery at University of Washington in Seattle. Unfortunately, he can't be with us today. He can tell why if he would like, but he is on the Zoom, and he's going to talk about a really well-received study that he's been able to accomplish as a pilot, and also well-received by the NCORE review. But it's still facing some challenges. So Dr. Sham, are you there?
I am. Can you hear me?
Sure can.
Yes, and we can see you too.
Oh, great.
Sort of. We can see you, but others will see you shortly.
I'm not much to look at, so no worries. Again, I'm Jonathan Sham. I'm a pancreas surgeon here in Seattle. And again, I apologize, I can't be there in person, but I was caught up in a COVID outbreak at a surgical meeting in New York last week. And so I'm quarantining just down the street from you guys. I'm here just to talk about our proposal and concept entitled Lanreotide for the prevention of pancreatic fistula. Just a disclosure that Ipsen Pharmaceuticals funded the phase 2 trial that I'll discuss briefly. So just a brief review, because I know there's probably not a lot of surgeons in the audience of what we're talking about here. Pancreatic fistula is also known as pancreas leak. If you recall back to your surgery clerkship, remember the 3 rules of surgery: eat when you can, sleep when you can, and don't touch the pancreas. That's because when you cut through the pancreas, it likes to leak enzyme-rich fluids that tend to cause problems in the body, such as bleeding, infection, intestinal dysfunction, organ failure, and even death. Rates of this leak have been really recalcitrant over the past 30 years and are somewhere between 15 to 25% after a Whipple and 20 to 30% for distal pancreatectomy.
Oops.
Was there a question, sorry?
No, I was saying, oops, as I was.
You're talking.
No worries.
Can you see this? Can you see the slide? Are we on the right slide, Jonathan?
Oh yeah, I'm controlling.
Oh, you are?
Yes. Yes.
Okay, go ahead.
That's okay. When it does occur, pancreatic fistula actually nearly doubles the cost of inpatient hospital stay. This is data at Memorial Sloan Kettering, and that leads to tens of millions of dollars in increased healthcare costs across the country each year. And also, probably more importantly, when it does occur, it's actually the single biggest predictor for decreased overall survival, even more so than.
Can I IT help? The slides are moving on the Zoom, but they're not moving for the audience here.
Oh, I see.
So maybe we should be the one to.
Okay, I'm gonna you just tell me to advance.
Oh, I see. I'm looking at mine, so maybe I'll stop sharing and I can just go back to you guys. How about now? Are there
Actually, you
slides?
can share as long as we know.
There you go.
Okay.
Are you guys starting slides now?
We are seeing the overall survival slide.
Okay, well,
And Zoom does not see anything. Here we go.
Okay, now we see,
so again, it's a big predictor of decreased overall survival. And if you can see some Kaplan-Meier curves there, you can see survival when fistula occurs in the 17-month range, and when it doesn't occur, it's in the 34-month range. So now I'm going to the next slide here, which is the phase 2 design. So we performed a phase 2 single-arm study at our institution of lanreotide, a single dose before pancreatectomy, to look at how it affected rates of clinically relevant postoperative pancreatic fistula. Lanreotide is a somatostatin analog and decreases the exocrine secretion of the pancreas for nearly a month after initiation. And you can see here on the chart on the right, we ended up having about 100 patients complete the study, 2/3 Whipple, 1/3 distal. 11% was the primary outcome rate in the Whipple group, and a really astonishingly low 2.7% in the distal pancreatectomy rate. And that's really far below, even though it's a single arm study, far below our institution historical data. Now I'm on the next slide entitled phase 3 design. So here, this was our initial concept, which essentially recapitulated the phase 2 design, just bigger with placebo controls, again, Whipple, distal, with and without lanreotide. We ran this by the INCOR Executive Committee and Catherine Guthrie in Statistical Committee, and really got the feedback that from a feasibility standpoint, this probably wasn't going to happen. And so we ended up settling, now I'm on the next slide, on essentially just distal pancreatectomies. And we chose that because that was really where the biggest effect size was seen. And it allowed us to have a much smaller sample size. And, we essentially everyone agreed that, if we're not going to see an effect in distals, we're probably not going to see it in Whipples either. Now, if you can see the primary and secondary outcomes on the right, the primary outcome is this so-called clinically relevant postoperative pancreatic fistula, which I'm happy to talk about later if you want to know the strict definition. And then secondary outcomes, including other important clinical course variation, leak, biochemical leak, so-called bleeding, delayed gastric emptying, time to initiation of adjuvant chemotherapy. And then I highlighted these in red. I'm not sure if the group in person can see this, but these are the two secondary outcomes that this committee really had a hand in adding to the proposal, and that's the change in the SMI at restaging, as well as the promised quality of life indices at 30 and 90 days. And we really feel like these have enriched the proposal significantly. So now on to updates. Again, we have initial support by the SWOG Executive Committee. We've submitted for the Coleman Fellowship. The really big hurdle we're facing now is the company that supported the phase 2 trial has informed us that they're no longer able to support the study because a generic has been released in the last couple months. And so we've reached out to the generic company to see if we can work something out with them, given the encouraging phase 2 data. And again, just lastly, I want to say thank you to the SWOG Surgery and Palliative and Life Care Committees, my mentors, Dr. Pilarsetti, Curian, and Dr. Krause here, and then of course, Catherine Guthrie and Sufan Wong for their help in developing the proposal. And again, welcome to Seattle. Sorry I can't be there in person.
Great, thank you so much. That was incredible. Dr. Krause, did you want to make a couple comments or see if there's anything else in the chat?
Any questions or thought? This is Frank, Sure.
Come on, you have to come up though, so that they can hear them. We're giving you a lot of exercise today, Dr. Weiskens.
I was stopped in the hall and asked by a couple of people to comment briefly on the information email we sent to all the members of this committee on the anthology that we have provided. So I could take either 3 hours or 3 minutes, so I'll take 3 minutes. And it evolved to the fact that we've had an annual symposium on healing and hope, poetic interpretations for the last 5 years under my leadership and another faculty member. This year, this evolved because of the pandemic, there was a great interest in having many poems on this subject. And so this evolved into an actual anthology, which developed, which is poems by 28 different poets up and down mainly the West Coast, but the lead speaker was from Illinois. And it's a very wrenching read, but I think you'll enjoy it when you think about it. We're thinking next year to have something like this, but perhaps dealing with the racist concerns that have evolved everywhere in all potential cultures and Black and et cetera, et cetera. I don't know if we're going to take that on or not. We'll see. But if you have any specific questions, just ask me. The information is in that email if you'd like to purchase it.
Thank you so much for reminding us about the anthology. And we did send it out to all of our members, and so they can see you here or email you with more questions. Were there any other questions for Dr. Sham that we wanted to engage in here, either online? I don't see anything online. Our fingers are crossed for you with the Copeman Fellowship. You've had great experience and great preliminary data there to share. So we'll just keep our fingers crossed for you.
Right.
Thanks to everyone here for their support.
Great. So then without further ado, we're going to end this meeting exactly on time at 7 o'clock. I can't believe that many of you are still here after probably 12 hours of this. And so we are very excited. And Dr. O'Rourke, thank you for hanging in there on the East Coast, and we wish you well. And so please,
we'll look forward to our monthly meetings, which will be again next month. And we look forward to all of you, new proposals, coming with new ideas, new partners, and a lot of great things going on. So thank you.
great meeting, everyone. Thanks.
I'm sorry, I didn't know you were going to announce the nursing. I apologize. Yeah, I was texting me. Oh, you have time for so then I said we have one more. And he said you were going to announce the nursing thing, so we didn't get to it. Oh, so I apologize. I didn't know where you were going. And I
put the slide in there just so that they didn't have to go back and forth.
It's fun. I just didn't know. And